Good afternoon. Buenos días y buen provecho. So, welcome to this afternoon lunch session entitled Refocusing on HIV in Europe, Addressing Challenges to Equitable HIV Outcomes for Communities of Greatest Need. I'd like to thank MSD for organizing this session and everyone for joining us for lunch and discussion about these issues. I'll ask you to keep eating, but to please turn off your telephones. You can hold questions to the end. Someone will be going around with question cards. There's also microphones you can use at the end. Whichever you prefer, you can ask questions in English. You can also ask questions in Spanish or even Andaluz. This is our program. My name is Jeff Lazarus. I'm a professor at the Barcelona Institute for Global Health here in Spain, and I'm the co-chair of the HIV Outcomes Initiative across Europe, looking at issues related to health-related quality of life, stigma and discrimination, and comorbidities. Previously, I worked for 11 years at the World Health Organization and at the Global Fund to fight AIDS, tuberculosis, and malaria. I'll introduce each of the speakers just before they come to the podium to speak. And I'll start by just saying a few words about this session. Why this session now? Why in 2022 do we still need to be talking about many of the issues we've been talking about for 10, 20, 30, or even more years related to HIV and AIDS? The main focus of this session is on inequities and inequalities, and despite the tremendous progress we've made in controlling the pandemic, unmet needs remain, especially with a number of key and marginalized populations. For example, migrants in Europe, older people living with HIV, younger people among the men who have sex with men population, migrant female sex workers, male sex workers, many groups. We won't list them all, but we will be discussing the challenges for these specific populations. Continued innovation in treatment and preventive therapies, policy frameworks, and care delivery systems and cross-functional collaboration are needed to end the pandemic, to improve health outcomes and quality of life with reduced inequities and without stigma and discrimination. It's been an exciting year. It's been a challenging year with the ongoing COVID-19 pandemic. But in May of this year, as you all know, in Geneva at the World Health Assembly, the highest decision-making body of the World Health Organization, a new WHO HIV strategy was passed. I'm just going to point out a couple of key issues related to this strategy that I think are important. This is a global health sector strategy. HIV is not discussed in isolation. It's discussed as a part of the health system and global health systems. And uniquely, for the first time, WHO combined HIV, sexually transmitted infections, and viral hepatitis into one strategy. And it's a strategy that goes from 2022, not 5 years like in the past, but all the way to 2030, aligned with the Sustainable Development Goals, where we know SDG 3 specifically mentions HIV, but all of the 17 SDGs need to be achieved in order to really end the challenges we're facing specifically in the field of HIV. It draws specific attention to the ongoing inequities, the unmet needs, but it also provides an opportunity to go beyond antiretroviral therapy and viral suppression. It's a more holistic document. It's focused on a people-centered approach, focused on long-term well-being and addressing health-related quality of life, multi-morbidity in people living with HIV, like non-communicable diseases, as well as, again, stigma and discrimination. You're all familiar with the 390s. You're familiar with efforts to go beyond the 390s, even to talk about a fourth 90 related to long-term well-being. And in this cascade of care that's presented in the strategy, and I encourage you to become familiar with it, look specifically at the 3 bullets at the bottom. We're no longer talking about just the 390s. We're also talking, as it sets out in the 3rd bullet of the WHO strategy, achieving good health-related quality of life. HRQOL, for the first time, is specifically mentioned as an outcome and an outcome that should be measured, and we'll be talking a little bit about that, because unfortunately, although it's called out as important in the WHO strategy, it's not addressed specifically in terms of having a quantitative target to measure it. So that's one of the challenges we face in the field, how best to regularly measure the health-related quality of life of all people living with HIV. With that, I'm going to introduce our next speaker, Eugenia Negredo, Dr. Negredo, who's going to speak on advances in HIV care. And to give us a clinical perspective, Dr. Negredo is a physician at the HIV unit in Germans Trias y Pujol Hospital in Badalona, just near Barcelona, where I live. And she manages a large cohort of people living with HIV there. And her research is focused on epidemiology, but as well as pathogenesis and the treatment of different toxicities, such as dyslipidemia, bone metabolism, and others. And her research fields are very varied, including addressing genetic variants associated with toxicities, immune activation, and inflammation. Over to you, Eugenia.
Hello, good afternoon. Thank you all for coming. Thank you, Jeff, and thanks MSD for this opportunity. Let's go to start with the clinical perspective of HIV care. Here you have my disclosures. And as you know, after almost 40 years, the HIV infection has become a chronic infection. We started struggled against opportunistic infections, trying to survive. Then we spent several decades trying to find the best antiretroviral therapy just to improve the quality of life of our patients, to decrease the toxicities. And now we are in a chronic disease era. In this era where patients are older, have more comorbidities, even polypharmacy, frailty, or other conditions, other situations similar to other chronic diseases that make us we have to change the era, and we have to change the model of care of our patients, because it's not the same a patient who starts his third year of treatment than a patient who is well controlled under treatment, stable, without comorbidities. Is also different a patient with many comorbidities, polypharmacy, even frailty, difficulties for the movement, or patients with social problems, migrants, patients with a stigma, patients with risky sexual behaviors, or patients, drug users. Everything is different. These profiles are different, and they need different management. Here in Spain, we have a multidisciplinary national project called National Policy, and whose main objectives is to stratify patients, stratify according the complexity of these patients, according to different criteria, and classifying them in these profiles that I mentioned before, just to identify the needs of these patients, the unmet needs of these patients, and then the most appropriate management of them. But the question is, what are the needs of our patients? Let me show you the results of our cohort. It's a small cohort. The over 50 cohort in our unit includes patients aged 50 years or over, and case controls matched by gender and age. Around 250 patients and 125 controls. And we include in the assessment not only medical aspects, polypharmacy, comorbidities, etc., but also we are including functional aspects, social aspects, psychological, mental aspects, and geriatric syndromes, etc. Considering all our results, we can see different things. For example, as we expected, the high prevalence of some more comorbidities in these patients, higher than in controls, is the dark bars. We expect these results, but we have to assess also geriatric syndromes that, at least in my center, we didn't know in the clinical routinary. For example, geriatric syndromes are also higher than in controls in our patients regarding sleep disorders, regarding falls, regarding hearing deficit, or also in sexual dysfunction. And we have to assess these geriatric syndromes because it's important for the patient. The third point is social aspects. The prevalence of single people among our patients is higher than in controls, and also people living alone, and this could be a problem in the near future. Also, we have more patients with depression, almost 24% of them, and we have more patients with cognitive complaints. And four, it's important, the rate of patients, the percentage of patients with polypharmacy, this means 5 or more drugs apart from the antiretroviral therapy, is a high percentage, similar to other cohorts or other European cohorts, and higher than in controls again. And this polypharmacy drives to prescribing errors, that it's very important in our cohort. 25% of our patients are receiving drugs that shouldn't receive. And 50% more or less of our patients are not receiving drugs that should receive, for example, vaccines or vitamin D. Taking all these results, we have to consider that apart from the comorbidities and polypharmacy, that I think that our assessment is quite adequate, quite correct. We have to assess also the functional aspects, the social aspects, the mental and psychological aspects, and also geriatric syndromes. And always considering and listening to the patient's voice. What is so important? It's important because sometimes the physician thinks that one thing is important for the patient, but the patient thinks that other things are important for them and it's not important for the physician. So it's very important to listen to the patient voice. We talk about the necessities, the needs. What are the characters of this film? No? We here have many specialists, but usually in our units, in most of them, I think, at least I think so, we have only 4 of them. The HIV specialist, the nurse, the administrative staff, and the pharmacologist from the hospital. But many of these profiles that I mentioned before need other specialists, need a psychologist, for example, people who are depressed, people using drugs, chemsex, people with economical problems, many different problems that we consider that this person could take benefit of a psychologist. Also social workers, also primary care centers, etc. And if in early stage, for example, in the prevention or in the identification of patients at risk, we also need contact with other specialists from hospital emergency room, for example, for STI centers, for community centers, from primary centers, from even public health. No? And it's not the same for everybody. Some patients need one specialist and others need another one. If we want to change the care model, we have to change the management model. What does it mean? This means that now we are working alone, at least in my hospital, and I think in many of the hospitals, we are in a HIV unit, we have our patients, we have our protocols, and we send our patients to another specialist in some cases, but we don't work together with the other specialists. We need to work with the same objective, try to find a common objective and work on that. And so this means inter-hospital relationships and also inter-hospital relations with other hospitals, reference hospitals, and as well with primary care centers, mainly in this case to assess early detection of HIV infections, for example, or for example for the best management of comorbidities. We need the primary care centers for many of our profiles of patients. As well, the community center. Well, the objective is to work together, not alone. Try to find time and space for meetings and to identify the needs and the met needs and how to manage these needs and how all together. And this means not a multidisciplinary team. This means an interdisciplinary teams. So we have to work on that. And that's all from me. And I think that we have a lot of work to do. Thank you very much.
Thank you very much, Eugenia. It's really fascinating to hear about the changes in models of care. And I'll be looking forward to the discussion with everyone because it wasn't that long ago that models of care were focused on the best ways to provide antiretroviral therapy. Now with that working so well in so many countries, not everywhere, but certainly at your hospital and across Spain, we need to be thinking about what you described as not multidisciplinary care, but interdisciplinary care. And it will be good to unpack that a little bit and hear what does that mean, who should be involved, and how do they get involved in that kind of care? What will it mean for the transformation of the health system itself? I'm now very pleased to present my friend, Professor Julia Del Almo, who will be presenting on equitable access to HIV care, a policy perspective. When I met Julia, she was, and still is, but before she joined the ministry, she was a professor of research in biomedical sciences at the National Center for Epidemiology, the Institute of Health, Carlos III in Madrid, Spain. I think it wouldn't be overstating that she's the master and commander of all things HIV policy in this country and really, I think, at the European level as well. So I'll be looking forward to your talk. Julia, the floor is yours.
Buenas tardes. Good afternoon to everybody. After giving this title of Master and Commander, what else can I say? It's not true, luckily for me and for you, Jeff. Thank you very much for being here, and thank you to MSD for inviting the Ministry of Health to talk about equitable access to HIV care from a policy perspective. Eliminating AIDS, as a public health threat by 2030 is included in the Sustainable Development Goal 3.3. And there is full commitment by the Spanish authorities to achieve the 95% indicators, together with zero stigma and discrimination, the reduction in new infections by 90%, the improvement of the quality of life of people living with HIV, which cannot be done without a fully involvement of the community. So, ending inequalities, ending AIDS is something we fully agree with. This work is currently conducted within the Division for the Control of HIV, STIs, Viral Hepatitis and Tuberculosis in the Ministry of Health. This division was created just over a year ago. It substituted the former National Plan on AIDS, which had been established in 1993. And similarly to other agencies, countries, institutions, we are working, integrating all these conditions together in a more integrated response. Let me spend a few seconds highlighting some of the peculiarities of health governance in Spain, because it's slightly different from other countries. Spain is a highly decentralized state, also in healthcare. The 1978 Spanish Constitution grants the right to health protection and healthcare to all citizens, but health care in Spain is managed at 3 different levels: the central state, the autonomous regions. There are 17 independent autonomous regions, very similar to federal states, and the municipalities. And this is a perfect scenario to talk about these different levels in health governance. So the central government is responsible for the basic principles and the coordination in health matters, for foreign health affairs, for medicine policies. And the autonomous regions are responsible for health planning, for public health, and for healthcare services, and the local councils for health and hygiene and the cooperation with public services. So there's a lot of coordination needed and involved in our country. Health policy are the decisions, the plans, the actions that are undertaken to achieve specific healthcare goals. And health policy is performed through national laws and through operational policies, such as rules, regulations, guidelines, administrative norms that translate laws and policies into plans and programs. And I want to share with you some policy instruments that have been implemented in Spain since 2018 with the aim to reduce inequity in HIV care. I will list them now, and I will go briefly into detail into one of them. The first is the Royal Decree Law in July 2018 to restore universal health. The Social Pact for Non-Discrimination and Equal Treatment associated with HIV in November 2018, the re-establishment of the Interdisciplinary Governance HIV Commission in 2019, a ministerial norm for the public funding of pre-exposure prophylaxis in November 2019, the publication of the plan to end HIV and STIs by 2030, the Royal Decree to create the division I've just mentioned, another ministerial norm to expand the indications for PrEP in December 2021, and we're currently working to ending HIV-related stigma and discrimination in the context of the Spanish presidency of the EU, which will take place in the second semester of 2023. So these are policy instruments that we can use to improve equitable access to HIV care. The restoration of universal health is undoubtedly the most important and powerful tool because it restored universal health. And this, I cannot stress, and you'll all agree with me how important this is, because it's the fundamental step to guarantee that HIV testing is linked to treatment. Otherwise, it's unethical to test people if we cannot link them to care and suppress the viral load. This includes undocumented migrants, and Jeff was mentioning undocumented migrants as a very, very vulnerable group. And indeed, this royal decree has a heterogeneous implementations in the different autonomous regions in Spain, and in some places, undocumented migrants, unfortunately, are having lots of difficulties accessing care in spite of this royal decree. The Social Pact for Non-Discrimination and Equal Treatment associated with HIV was approved by the former Minister of Health, Maria Luisa Carcedo, in November 2018. And it was a long requested demand from civil society. I believe, Diego, from 2011, you were asking for this pact to be implemented. And this is a pact that has been uptaken by the Minister of Health from the civil society to provide a consistent, stable, multi-sectorial and intersectorial response to address the structural discrimination against people living with HIV, as well as other forms of discrimination. The aim of this pact is to eliminate stigma and discrimination towards people with HIV through actions by public administration, by political actors, by the academic and the private sector, in close collaboration with civil society. There's been lots of outputs of this pact, but I want to highlight two of them to you. The first one was the Council of Ministers agreement that just followed the approval of this pact a few days later. And this agreement approved the instructions to update all the calls for exams for civilians and military officials, health professionals, administrative staff, that eliminated HIV as a generic disqualifier to access public service. It really didn't make much sense, but HIV still remained as a generic disqualifier. So through this amazing work, because it was really amazing working with the Ministry of Defense, with the Foreign Office, with the Home Office. I mean, it was really amazing that all these generals and all these people were sitting in the same room, and they were acknowledging that HIV could not be a genetic disqualifier. And because HIV opens the door for services for other conditions, this was also implemented for people with diabetes mellitus, for celiac disease, and for psoriasis. All these public calls have been reviewed, and this disqualifier has now been eliminated. Another important step was the agreement of the two interterritorial councils of the states between health and social services that took place in October 2019 to forbid the denial of admission of elderly people with HIV into publicly funding residential homes. We knew from civil society that some residential homes were denying access to people because of the condition of HIV. This is unlawful in Spain. This is illegal in Spain now, so the community has the tool to sue the institution if this takes place. We reestablished the annual governance of HIV, our national commission, that had not met since 2011, in spite of having a royal decree that granted that this commission fully interdisciplinary with all the actors in the HIV response, from civil society, public administration, local administration, regional administration, academic societies. I mean, it is a really, truly governance interdisciplinary commission. It met for the first time in 2019 after, as I say, more than 9 years. And in the first agenda, we wanted to raise the implementation of the Social Pact and the need to approve PrEP and to talk about chemsex and the need to do actions to reduce harm in the context of chemsex. PrEP in Spain had been approved by the Spanish Agency of Medication in 2016, but no decision had been made regarding its public funding. And because antiretrovirals in Spain can be only dispensed in hospital pharmacies, there was no possibility to access PrEP in our country rather than buying it through internet, which in Spain is illegal. So there had been a lot of political action with the community and many of us in the previous life, in the academic sector, the clinical sector. There had been a proposition not of law in the Spanish Parliament in November 2018, which had been unanimously supported by all political parties, so we had a lot of support from that side. So from the General Directorate of Public Health, in collaboration with the General Directorate of Pharmacy, we took the PrEP issue to the National Committee of Public Health, to the Governance HIV National Committee, with the support of our National Committee of NGO, el COAC, which had been doing a lot of community and advocacy work in the previous years. This led to the approval of the public funding of PrEP in November 2019, and since then, the number of products, implementation issues, guidelines has been enormous, all in collaborative work with the different actors. This meant that only 2 years, less than 2 years after its implementation, with the COVID pandemic in between, which I don't need to say that really was not helpful, less than 14,000 people in Spain were on PrEP. And this is our Minister of Health, Carolina Darias, celebrating uptake of PrEP in a party we call PrEP Party, which we celebrated after, during Gay Pride in Madrid this last summer. We're currently working towards the Spanish presidency of the EU, as I said, second semester 2023, working with ECDC, WHO, Europe, UNAIDS, and SEICIDA. We are organizing a high-level meeting, we hope by July 2023, and a declaration to end stigma and discrimination in the context of the EU presidency. Thank you very much again, and I look forward to the discussion in a little while. Thank you.
Thank you very much, Julia. I found that incredibly inspiring. I mean, it's really a textbook example of what countries should be doing to implement good HIV policy. So if your country has not achieved what Spain said, you should definitely get a copy of this presentation because it has all the steps of what needs to be done. I don't think we'd have been so successful in HIV in Europe without the existence of community checkpoints. There are checkpoints across the continent in Denmark, in Portugal, in Greece, in France, many more, in Barcelona, and here in Sevilla. And so I'm very pleased to invite Diego Garcia, who will be presenting on remaining unmet needs and provide us with the community perspective. Diego is the director of the Sevilla Checkpoint here, a specialist community center focused on the early detection of HIV and other sexually transmitted infections. He's heavily involved in improving the provision of HIV care and is a member of the European AIDS Treatment Group, the European Community Advisory Board, and coordinator of the Spanish CAB FEAT and community representation of EACS, the European AIDS Clinical Society Co-Infection Panel. The floor is yours.
Thank you. Well, thank you. Thank you to MSD for inviting me to this symposium, and thank you to the audience for sharing this precious moment, the lunchtime, being with us here. And I feel honored to be in this table because I'm sharing, experiences with Julia. I think Julia has been not only instrumental, that's not the word, but I cannot find it. Master and commander maybe, but instrumental is not the word either. I mean, she's been an activist and now in a position that she can really make changes in a political way. And we, the community, we feel so proud about her and her work, and she knows. And Julia, you are in our hearts, and you know that. So we really appreciate what you are doing. Eugenia, I've been working with her also. I've been working with Eugenia also in aging and collaborating as community in getting data, because at the end of the day, we need data. And when we need to prove any advance or how things are going, the community is essential because we are the ones, at the end of the day, that we produce those data. So we've been working together, and it's been a pleasure. I know her also for a long time, so I feel really honored to be with her. And Jeffrey, I mean, he's the father of our quality of life, our zero stigma and discrimination. So, I mean, a big applause. This is really something to be here with him. And to tell you the truth, I wouldn't like to be giving this speech because that will mean that there is not unmet needs. So that will be absolutely wonderful. But unfortunately, 40 years since, HIV came into our lives, and still we are talking about unmet needs. And there are so many that I have to read them. Because if I don't read them, I may forget some unmet needs. So really, I wish I wouldn't have to be giving, this long speech of things that really need to come. What you are going to see, well, I have no personal disclosures. My organization, NGO, does have funding, public and private. But stigma, discrimination and criminalization of people living with HIV is still today, unfortunately, present in more aggressive or subtle ways in most countries. Criminalization laws exist in many states within the USA, and punitive laws become a reality as we start moving east towards many Eurasian and African countries. Stigma, discrimination, and criminalization pose big barriers worldwide to achieve the WHO targets for 2030. And this connects on how, as societies, we still perceive and integrate in our policies minorities, migrants, sex work, or sexual health rights. Stigma and criminalization are key factors on why people do not test frequently for HIV and other STIs. The lack of routine testing that we see in our societies in many countries and for many communities is because they feel persecuted. They feel judged, or even at life risk for being gay, for being trans, for being a sex worker, or for being a woman. Those fuel late diagnosis and AIDS cases even in Western countries. In Spain, we have governments who grant people living with HIV rights. And a big step forward has been done during these last few years to negotiate with different ministries, government offices, and civil society the update of old-fashioned directives in several laws, as Julia said, that presented a ban for people living with HIV and resulted in serious discrimination barriers. For example, HIV is no longer an exclusion criteria for joining the military. I mean, this may sound something, but it's really important to quit those bans. And HIV in Spain is no longer considered a barrier, as Julia said, to access residential services for the elderly. We are getting old. I'm 57, so I'm approaching. So really, I mean, in how many countries still there is a ban if you are HIV positive to get to a residency? So despite these most celebrated advances, even in Europe, we see year after year largest numbers of new infections. And as the rest of the continent, we do not manage to lower the too high rates of late presentation and diagnosis. And we reach more than 50% Prospective studies show that between 66 and 80% of people with HIV had previously visited a health professional with symptoms compatible with HIV infection, and they were not offered a test. Routine testing, not only of HIV, but of different STIs, should be offered in most healthcare settings, and greater effort should be done to fund accordingly the NGOs and community centers that throughout the country are offering person-centered services, judgment-free environments, and quick diagnosis and treatment with linkage to care populations which find difficult to reach traditional health services, and yet they are at a greater risk of sexually transmitted infections. During the COVID-19 pandemic, when the health system almost collapsed, we continued offering our services face-to-face and also developing home delivery options for those who couldn't reach the centers. During those hard times, and maybe because of those hard times, people had more compulsive sex under the effect of substances, and STIs were managed and treated by us, by the checkpoints, in a moment where the health system was mostly COVID-oriented and little space was left for conditions like STIs. Recently, we all are suffering a new health emergency threat, monkeypox, and although we have offered the checkpoints ourselves to the local health authorities to help beyond raising awareness, no answer was made. And the lack of real collaboration between health authorities and point-of-care clinics, NGOs, and checkpoints is present regarding the providing of PrEP services too. Worldwide, we have celebrated the arrival of new prevention tools, mostly antiretrovirals that, taken appropriately, can prevent HIV infection in all most affected population: MSM, cis women, trans women, and men, also in drug users. Great rates of efficacy with no efficacy limits linked to ethnicity. PrEP opens up a big opportunity to cut down the numbers of new infections. According to WHO, 1.5 million people acquired HIV in 2021, and in Spain, 6 people became infected in 2020 every day, even during the toughest lockdown times due to COVID-19. If we have the tools, why people are acquiring the infection? If we look at the uptake of PrEP in large areas of the world, PrEP still is not available. Where it is available, it is not easy accessible. And where it is available and accessible, then we have stigma. And again, stigma, barriers, social misconceptions, ethnic inequity in access. Poverty or health systems that, instead of facilitating the uptake, pose bureaucratic barriers that make difficult for people to access this prevention tool. This rigid scheme to get PrEP makes it very difficult for transgender women, migrants, sex workers to access that prevention tool. I'd like to share also my personal experience that living with HIV for 26 years and aging, I have gone through some life-saving milestones and obviously we have improved our quality of life through all the clinical outcomes that we have lived during these 40 years. But all this important clinical management and milestones hasn't always come with the big steps, improvements in quality of life. In Spain, for example, certain regions are imposing restrictions and building barriers for migrants to have medical care and medications. Most hospitals lack integrated services, as Eugenia said, for chronic diseases. And the hospitals are becoming unfriendly places for an aging population who find extremely difficult to manage appointments with different specialists to treat their comorbidities. And for example, Seville, the province, needs 6,000 nurses to match the European recommendation per habitat. There are certain initiatives that we find in Spain that are moving in the right direction. And as Eugenia said, stratification of patients goes into this field of making things easier for getting the old population get good services. To finalize, I would like also to bring your attention to where we are and how we can improve our response to commit to the UNAIDS targets for 2030. To reach the new proposed global 95, 95, 95, we still need to redouble our efforts to avoid the worst-case scenario of 7.7 million HIV-related deaths over the next 10 years. Increasing HIV infections due to HIV service disruptions during COVID-19 and the slowing public health response to HIV. Remember that HIV continues to be a major global public health issue that has claimed 40.1 million lives so far. In 2021, 650,000 people died from HIV-related causes, and 1.5 million people acquired HIV. We are very far from the target of 2,100 or less infections a year. In the 72nd session of the WHO Regional Committee for Europe held in Tel Aviv on September this year, the regional action plans for ending AIDS and the epidemics of viral hepatitis and sexually transmitted infections agreed on a resolution for a 2022-2030 period. It is urgent to ensure that the needs of the people affected by HIV, viral hepatitis, and STIs, and the needs of key populations at risk of acquiring these diseases are addressed through nationally defined, people-centered, decentralized, gender-responsive, and sustainably financed service delivery. I mean, this is crucial, this is very important, and this is a mandate. So we really need to think that mandates are to be covered. We are all facing difficult and uncertain times. We are entering an era of crisis, war, economical restraints, cut downs in civil rights, and also in migratory rights. We must renew our commitment and redouble efforts to keep on giving steps forward and be prepared to end this and the new to come epidemics. We need to allocate enough funding for life-saving programs and innovative treatments tailored to people's needs. We need to change our healthcare systems, moving towards chronicity and explore partnerships with civil society. We need to ensure access to most effective and convenient preventive tools, making them accessible to everyone who really needs them. It's about time to fight discriminatory attitudes, change criminalization laws, expand knowledge about HIV, and expand knowledge about sexual health. All these recommendations may sound difficult to enforce, but we are well on the way for years now. We have the knowledge, we have the tools, we have the need. So give the funding, have the will, and we will make it real. Thank you.
Thank you so much, Diego. The only thing I would disagree with is that the honor is really ours to be on the stage with you, living with HIV for over 25 years, fighting every day, founding and leading the checkpoint that's been so transformative in reducing the number of unmet needs. I do hope we can share the stage one day when that list is very small or non-existent. I also agree with you that it would be nice not to be the next speaker and to go straight to the discussion, because I do want to make sure that we can hear from the audience and that you can engage with all of the panelists. But I am going to say a few words on refocusing on HIV in Europe and how we can work together to achieve a common goal. I'll be focusing often on Europe, but really this is a global message. First, giving a think about HIV inequities. Here are my disclosures. So UNAIDS has again set out last year what we mean by inequalities. And they write that inequalities are one of the key reasons why the 2020 global targets were missed. The inequalities that underpin stigma, that underpin discrimination, and HIV-related criminalization, as you mentioned, still prevalent in so many places. They enhance people's vulnerability to acquire HIV and make people living with HIV more likely to die of AIDS-related illnesses. So the strategic priorities really need to be centered on comprehensive, people-centered HIV services. Again, something you mentioned, and also Eugenia, that we'll be coming back to. What does it mean to make models of care people-centered? The International AIDS Society is going to be working on this issue. They've been developing it. They have a special issue of their journal coming where it's going to be looked at in a whole range of aspects so we can really start to transform our models of care to go beyond viral suppression. We need to remove societal and legal impediments to ensure an effective HIV response. We already heard the changes that have been made in Spain. When I first came to Spain, 5-6 years ago, there were still laws on the books about entering the military, the police, if you were living with HIV, and those have been changed. There are still laws on the books around the world, including in Europe, that prohibit and limit people living with HIV from getting the jobs they'd like, from getting the health insurance and other mortgage insurance and so on that they need. And to do that, we need robust and resilient health systems. We saw what happened during the COVID-19 pandemic here in Spain, across Europe, and in so many other countries as our health systems collapsed under the weight, and particularly our infectious disease clinics and departments, which were turning people away and encouraging them not to come in person, to get tested, to get linked to care, to get their treatment, because the health system wasn't resilient enough to handle the pandemic, and we need to make sure that we get back on track now, because we've had a huge setback over the last 2.5 years. You already mentioned the move from the 390s to the 95, so I won't go through all of them on the screen, but we do have a series of targets in the UNAIDS and WHO strategies related to getting under 10% in a range of areas, including on stigma and discrimination, and over 95% there on what we were formerly calling the 390s. We have a lot of data. We know what's going on in 2022. We've well documented the unmet needs. Now is the time to overcome them. And criminalization is one that I'm very surprised. When I was at WHO 15 years ago, this was a priority issue, and the fact that we've gone another 15 years with criminalization in so many countries means, for me, it's really one of the top unmet needs, because it feeds into all of the stigma, the discrimination, the care avoidance that is hindering the response to this pandemic. The UNAIDS and WHO strategies have a series of projections. They have strong modeling about where we're going and what's going to happen if we don't implement the tried and tested evidence-based measures that they set out, but what will happen if we do, and how we can actually, by 2030, achieve the end of AIDS. We have the tools, we have the knowledge. In many countries, we have the policies. Now we need to make sure we have the will, and as you also mentioned, the financing everywhere to do that. Stigma and discrimination go hand in hand. They're often mentioned together, but we do need to unpack them a little bit and understand how this is very circular. Discrimination, like the law that was prohibiting people to enter the military, feeds into the stigma that people living with HIV aren't able to take on those kinds of jobs. That can lead to increased discrimination, and it becomes very circular. Discrimination is often related to rules and laws and legislation that can be overcome. Stigma is a much bigger challenge. We need to be thinking about that structural stigma, but also public stigma, stigma within the healthcare system, and how all that feeds into self-stigma and the dangers of self-stigma that lead to care avoidance and ultimately worse health outcomes. So what can be done? I work in the healthcare system, and we need to ensure that all stigma and discrimination is removed from all parts of our healthcare system. From the GP level to our university hospitals, we need to make sure that there are no discriminatory rules and regulations on the books anywhere. We need DSD, we need differentiated service delivery. There's a very nice IAS systematic review on what this means, but there is no one-size-fits-all for care. We'll come back and talk about that in terms of models of care. I've already mentioned the importance of legal and regulatory reform, issues related to gender. Over the last years, we've seen a sea change in understanding and recognizing gender, but it still hasn't been, let's say, implemented or applied or understood or recognized in all settings. Digital health technologies, digital health therapeutics, apps made a big leap forward here during the last couple years. When we couldn't send people, or people couldn't get to the hospitals and clinics, they were encouraged to turn to online tools. We need to make sure that that doesn't result in a digital divide where people with less resources are left behind. Less resources to have the connectivity, to have that video conversation, or even to have the ability to have a private setting to be able to have confidential discussions with their care provider. So while some of us can move forward into this digital world, we need to make sure, again, that we leave no one behind, and the field of HIV and AIDS can make a big difference for everyone by recognizing this, because the whole world is moving towards digital, but there are people who are not moving with us. As always, this is only going to happen if we have multi-sectoral partnerships. We need ministries of health to be working with ministries of social welfare, but also ministries of justice, ministries of interior. We need a whole of society approach, just as it's well set out in the Sustainable Development Goals. This will also mean increased and improved health workforce training, but we will come back to that when we talk about the models of care. Some of the priority actions to tackle inequities include the critical role of the health sector in enabling and leading this kind of multi-sectoral health in all policies approach to remove structural and systemic barriers. As researchers, we know the importance of disaggregated analysis of data by sex, gender, age, and other relevant population characteristics. Often it's collected, not always, but when it is collected, many times it's not shared back. We need that level of data in order to orient our interventions to be effective. Also to be able to monitor over time and compare between countries and within countries. And finally, as Julia mentioned, that continued push to make sure that universal health coverage is truly universal. We may have the rules and regulations and laws here in Spain that protect the right to health for all migrants, but we know, I believe it's over 1,000 migrants right now in one of the autonomous communities not able to access the HIV care they need. That should not be happening in this country. It should not be happening anywhere. All of this leads to the paradigm shift. One of the main themes here at the Fast Track Cities Conference is a paradigm shift heralding a new era in HIV care, moving from the disease-centered HIV care approach that made sense early on in the pandemic to people-centered HIV care with a focus on long-term well-being and health-related quality of life. Together with Julia, Nikos Deres, who just left, and others in the community, and researchers and policymakers, we brought this up over 5 years ago in time for the earlier WHO and UNAIDS strategy, fearing that with the 390s, the focus would be on just viral suppression. We called for going beyond viral suppression, and we can call it whatever we want, whether it's a fourth 90 or simply long-term well-being while living for people living with HIV. We need to make sure that we understand the concept of good health-related quality of life, but also that we're monitoring it in all populations every year to be able to carry out that analysis over time and between populations, both subpopulations of people living with HIV and also those not living with HIV. WHO has a health systems framework that I think is really helpful to understand how we can build collaboration within the health system. I won't go through it all, but I'll point out on the top right, WHO says the ultimate goal of any health system is to lead to improved health. And here I'll direct your attention to what's in parentheses. Back in 2007, in their wisdom, they added by level and equity. And what they mean is that when you achieve 95, 95, and 95% in your country, that's not enough. It has to be for every single population, and that's what we mean by equity, a cornerstone of public health, and what should be a cornerstone of our response, but still we have that very long list of unmet needs, so many of them relating to inequities. The paradigm change in health systems was to start to talk about patient engagement, and when we developed this a few years ago, to add in communication, to have better communication within the health system. Sometimes there's discrimination and stigma that's entirely unintended, and we need to recognize that. Sometimes it's there on purpose. From that transformation to engaging with patients, to communicating better within the health system, WHO presented the 6 building blocks I showed earlier as a people-centered health system, always keeping people, not just patients, but everyone in the center of the health system, and the lines between the different building blocks showing the dynamic interaction between the different parts of a health system that need to be much better coordinated, and that starts with better communication. I'll go through this rather quickly, but there are things we can be asking of the health system. If we have a national strategy or plan, where affected communities, including people living with HIV, involved in developing them, involved in monitoring them? Do we have a workforce that's fit for purpose? Do we have the budget to do what is set out in our strategies and action plans, and the capacity to monitor? This is so important, and when you look at the UNGAS reporting and other reporting to the multilateral agencies, we see many countries not reporting or unable to report on all indicators, or simply falsely reporting, which is why there's a system of shadow reporting so that the community can engage in feeding back what's really happening on the ground. Are the strategies engaging all affected populations, or do they just look good on paper, but in effect they're not reaching the people who really need to be reached? And finally, is the data easy to understand? As an epidemiologist, I still get challenged reading some of the available data. We need to make sure the data is easier to acquire, and certainly very easy but comprehensive when it's shared with us. We know marginalized groups are at a higher risk of vulnerability, so I won't go through all of the details of the Nobody Left Outside health systems checklist, but this was an effort to co-create with a range of marginalized populations across Europe through a coalition effort in which the health risks are identified, the barriers to care are identified, and the outcomes, the low service uptake, what happens when we have these barriers, and what are the concrete health outcomes, increased morbidity, increased mortality, excess care costs, public health threats, and a risk to achieving the Sustainable Development Goals, not just Goal 3, focusing on health, but all of the goals. So marginalized, underserved groups will often say that they're not so hard to reach, it's the system that's hard to reach, and that's why the innovation of having checkpoints has been so transformative. It listened to the population and it develops services that work for that population and that are easy to access. Think of that image Diego showed of the prep point in Barcelona. It's not far from my office. It looks like a storefront. It's at street level, and you can just drop in and get answered the questions you pose by your peers and get the care you need, but then also linked up with Eugenia's hospital and other hospitals to be able to monitor and get more specialized care if that's needed. I won't go too in detail on the service model since we'll be discussing that, and Eugenia already mentioned it, but people-centered means adapted to users' multifaceted but also evolving and changing needs. They need to be integrated. That may be co-location. Co-location may not be feasible. That may be through video. That may not be feasible. But then we need to have good linkage through a strong referral system and ideally with peer support as a part of that. They need to be adapted for accessibility, no stigma and discrimination, suitably financed, led, and governed. This is the group of organizations from across Europe that worked on that checklist to improve healthcare access for marginalized, underserved populations. This can be applied to HIV care or really any other kind of service by taking a look at the checklist and asking key questions, starting with, were community representatives involved in the design of the service? Are health and social care needs of the community being considered? We cannot address health without addressing the social aspects, and we know that WHO defined all the way back in 1946, but adopted in their 1948 Constitution, health is not merely the absence of disease or infirmity, but also a complete state of physical, mental, and social well-being, and I think we're failing on the social and mental well-being for people living with HIV around the world. Great. So as I start to conclude, I want to think about the convergences: integrated care, health system strengthening, patient, or what we're now calling people or person-centered care. When a patient comes into the hospital, when they're lucky enough to come into a well-functioning hospital, when they're lucky enough to have all of their comorbidities being tested and assessed and diagnosed, when they're being asked about their symptoms and their concerns, which is often not done in the clinical encounter, they may still find that it's not enough. All of this information being relayed to them. Where do they go? What time do they go? Do they have to come back for multiple appointments? There are opportunity costs, and these opportunity costs, these challenges, hit the marginalized populations most. So we need to think about what's going to work for those populations and how can we have that kind of interdisciplinary care that Eugenia mentioned. The HIV Outcomes Initiative that I mentioned across Europe has developed a series of fact sheets that we use to engage with policymakers at the European and the member state level. There's fact sheets on discrimination, a fact sheet on stigma, a fact sheet on health-related quality of life. And all of those discussions led us, again, together with Julia and people and experts from around the world to develop a global consensus on advancing the long-term well-being of people living with HIV. This came out a full year before the new global health sector strategy from WHO, in which it tried to set a focus on 5 key aspects that had been regularly overlooked, not by everyone, not in every setting, not by every clinician, but in broad strokes, the monitoring and reporting of comorbidities is not being done enough. The frameworks for healthy aging, frailty, and functional ability are not being well understood and applied. We still have those access barriers that we've mentioned several times. We are not collecting and documenting health-related quality of life. There are isolated studies and good examples from Australia, from Sweden, from the United Kingdom, but in most countries, almost all countries, this is not regularly collected, and we don't have agreement on what tools are best to do that on a regular basis. 4 of the key areas then, as I start to conclude, where action is needed to improve HRQOL, the comorbidities, the aging, the measuring or monitoring with people or patient-reported outcomes, and combating stigma and discrimination. We need to integrate patient-reported outcomes and patient-reported experience measures into clinical practice. These can't be one-offs. They can't just be a part of our research activities. They need to be a regular part of the clinical encounter. We need the people-centered integrated health service delivery models that we'll talk about, leaving no one behind in terms of access to digital health technologies, and recognizing the importance of social determinants of health and inequity, stigma and discrimination, mental health, disability, and life rehabilitation. These recommendations are to focus on stigma and discrimination, to tackle HIV inequities, to promote the transition of health systems into integrated health services, to integrate PROMs and PREMs, and to develop a monitoring and evaluation framework. So in conclusion, it's October 2022. It's surprising how many unmet needs there are. It's surprising thinking back almost 20 years ago to the UN's Declaration of Commitment that so many populations called out then as key populations are still being left behind. As Diego mentioned, we now have an aging population. That's the good news. Are they getting the care they always need? I think that's some of the bad news. So we need to be considering how the system, how the care needs to transform to address NCD's mental health, social well-being, stigma, and discrimination. And again, I just draw your attention on the right to the new WHO continuum of care that specifically calls out the importance of the outcome of HRQOL, and now we need to discuss how to measure it and how to ensure the long-term well-being of all people living with HIV. Thank you. So I'm conscious of the time. I'd like to thank everyone who took your lunch break here with us, but I'd like to thank the speakers. Thank you so much, Julia, Eugenia, Diego, for providing such different perspectives on this panel. Thank you to the audience for engaging. Thank you to the team at MSD for being able to shine a spotlight on unmet needs and how we need to reduce inequities however they rear their ugly head. So thank you. Have a good break, and see you at the next session.
Thank you.